Here's our game plan for today. First, the core framework, then clinical recognition, damage control resuscitation, exam pearls and traps, and we'll wrap up with some active recall testing.
All right, Section 1, the core framework. We use this classification system to estimate blood loss entirely based on clinical signs. Think about how a patient's physiological crash maps out. In Class I and II, blood loss is under 30%. You'll see the pulse creep up, sure, but blood pressure remains totally normal. Now, the critical inflection point is Class 3. That's 30 to 40% blood loss. This is where compensation completely fails. The pulse shoots past 120, blood pressure finally drops, and urine output just plummet. By Class 4, with over 40% loss, the patient is in severe extremis, with practically negligible urine output. Notice how the pulse spikes and urine drops drastically long before the blood pressure bottoms out. That is a crucial takeaway.
Moving on to Section 2, clinical recognition. When you're actually standing at the bedside, you absolutely must recognize the difference between a patient who is compensating and a patient who is crashing. In early shock, so classes I and II, those compensatory mechanisms are working overtime. The patient might have mild anxiety, and you'll definitely see tachycardia, but their blood pressure is maintained. It's often perfectly normal. Now contrast that sharply with decompensated shock in classes 3 and 4. Here, the compensation has totally failed. You're going to see clear hypotension, marked tachycardia, confusion or lethargy, and poor peripheral perfusion with oliguria, meaning very little urine output. So the absolutely crucial point here is this. Hypotension is a late sign of hemorrhagic shock. Let me say that again so it really sticks. Hypotension is a late sign. If you wait for a drop in blood pressure to diagnose shock, you're making a potentially fatal mistake. The body will fiercely vasoconstrict to maintain that pressure until it simply can't hold on anymore. Section 3, damage control resuscitation. When your patient is in decompensated class 3 or 4 shock, what are the urgent management protocols? Well, there are 3 precise principles you've got to follow. Step 1 is permissive hypotension. We target a systolic blood pressure of 80 to 90 millimeters of mercury until the bleeding is controlled. You don't want to pop the clot. But note this vital exception. If there is a traumatic brain injury, you must maintain adequate cerebral perfusion, so permissive hypotension does not apply there. Step 2 is hemostatic resuscitation. This means using balanced blood products, packed red blood cells, plasma, and platelets. And Step 3, rapid hemorrhage control through surgery or angioembolization.
So how does this actually apply by class? For Class 1 and 2, we generally use warm isotonic crystalloids. But look at Class 3. You need to activate the trauma protocol and give early blood products. Do not just flood them with excessive crystalloids. For Class 4, you are initiating the massive transfusion protocol immediately. You also need to aggressively correct the lethal triad, which is hypothermia, acidosis, and coagulopathy, and get them straight to ICU care. Let's dive into Section 4, exam pearls and traps. Whether you're on the wards or taking your boards, examiners love to test your situational awareness. So here are the most common, dangerous pitfalls that routinely trap test takers. First up, as we just hammered home, waiting for hypotension to diagnose shock. Second, giving liters and liters of crystalloid fluid in severe Class 3 or IV shock instead of blood. Third, delaying definitive hemorrhage control. Fluids are just a bridge to surgery. And finally, a massive trap you must watch out for, forgetting that elderly patients, athletes, or folks on beta blockers might have completely atypical responses. A patient on a beta blocker might literally be bleeding out and never become tachycardic. On the flip side, lock these high-yield pearls into your memory. Tachycardia is the earliest clinical sign of shock, period. A narrow pulse pressure, which is caused by that compensatory vasoconstriction, is an incredible early clue. Never, ever ignore the Foley catheter. Urine output is one of the single best indicators of adequate end-organ perfusion. And lastly, hemorrhage control is the definitive treatment. Section 5, active recall test-in. Let's run through a quick Socratic simulation to see how well you can apply what we've just covered. Here's your first clinical scenario. You've got a trauma patient, their pulse is 110 beats per minute, blood pressure is normal, respiratory rate is 24, and urine output is 25 milliliters per hour. Take a second and lock in your answer. Is this patient in Class I, 2, 3, or 4 shock? The correct answer is Class 2. A 15 to 30% blood loss produces tachycardia and mild oliguria, but it perfectly preserves the blood pressure. Our main exam pearl here is that a completely normal blood pressure does not exclude significant active blood loss. All right, next case. A trauma patient arrives with a pulse of 132 per minute. Blood pressure is 85/60. The patient is confused and urine output has dropped to just 10 milliliters an hour. Is this class 2, 3, 4, or neurogenic shock? The correct answer is class 3. This patient has officially decompensated. The combination of hypotension, marked tachycardia, confusion, and low urine output tells you they're in class 3 hemorrhagic shock and require immediate blood transfusion, not just crystalloids.
Let's do a rapid-fire fundamental question. Which of these is the earliest sign of hemorrhagic shock? Hypotension, reduced urine output, tachycardia, or cyanosis? Think about what the body actually does first to compensate. You got it, tachycardia. Compensatory sympathetic activation drives up the heart rate to maintain cardiac output long before the blood pressure ever drops.
Now, let's shift gears to an oral board simulation. Imagine your examiner looks across the table and asks you this vital physiological question. Why is blood pressure often normal in early shock?
Because compensatory vasoconstriction and an increased heart rate maintain perfusion initially. This vasoconstriction is exactly why we see a narrowed pulse pressure as an early clue.
And here is your final Viva question of the session. The examiner asks, what is the definitive treatment of hemorrhagic shock? The definitive answer is the rapid control of bleeding via surgery or angioembolization, along with appropriate blood product resuscitation. Remember, IV fluids and blood products are strictly temporizing measures. They just keep the patient alive long enough for you to stop the leak. We're going to end this explainer on our golden rule. Treat the patient, not the estimated blood loss. Use the classification as a framework for sure, but always look at the person in front of you. The signs are there in the pulse pressure, and the urine output. The only real question is, when the monitor looks reassuring but the patient is quietly bleeding out, will you recognize the crash before it happens? Keep this knowledge sharp, stay vigilant, and I'll see you in the next explainer.